All right, good morning or afternoon. I don't know where everybody's coming from, joining us today, but Brandon here at the National Minority Equality Forum. Apologize for some noise in the background. I'm in the city, and so sometimes you can't avoid the city. Our very own, I call her our own MacArthur, in-house MacArthur Scholar Fellow, Gretchen Wartman will lead today's webinar on the state of mental health. And once you hear her present and her colleagues on this call, you'll see why. So Gretchen, I'm turning it over to you.
Thank you, Brandon, and good afternoon. My name is Gretchen Wartman. I'm Vice President for Policy and Program of the National Minority Equality Forum, and in that role, I am Director of our Institute for Equity in Health Policy and Practice and Director of our National Alliance for Brain Health and Awareness. Today, in recognition of Bebe Moore Campbell National Minority Mental Health Awareness Month, our policy briefing will focus on disparities in screening, diagnosis, and treatment of serious mental illness. Serious mental illness, or SMI, can generally be defined as mental, behavioral, or emotional disorders resulting in serious functional impairment that substantially interferes with or limits major life activities. These diagnoses can include, but are not limited to, schizophrenia, major depressive disorder, and bipolar disorders. Various studies estimate that more than 14 million adults have SMI, with only slightly more than half receiving mental health treatment. In addition, studies indicate that people from racial and ethnic groups that are in the minority in the United States are especially vulnerable to overdiagnosis and negative outcomes regarding SMI. A meta-analysis by Mora and Mamani in 2017 highlighted different racial disparities that exist for people of color with SMI. To note a few, people from racial and ethnic groups that are in the minority in the United States, especially Black Americans, are more likely to receive a schizophrenia diagnosis than white Americans. Black Americans with SMI are more likely to be hospitalized than any other racial group. Further, people from racial and ethnic minoritized groups have lower utilization of outpatient treatment compared to white individuals, have treatment attrition rates that are much higher than those for people from racial and ethnic minority groups, and receive poor quality of care and less follow-up after diagnosis. We are so pleased that three notable panelists are joining us today to share their perspectives on real or perceived structural barriers or other hesitancies that may impede improvements in mental health services research, delivery, or finance. Dr. Rimal Bera is chairman of the Mental Health Working Group of the Alliance for Patient Access. He is a clinical professor of psychiatry at the University of California, Irvine Department of Psychiatry. He serves as a medical director for Universal Care Behavioral Health for California and as medical director at the John Henry Foundation in Santa Ana, which is a high-level center for the treatment of schizophrenia. Ms. Pamela Price is Deputy Director of the Balm in Gilead. Ms. Price is a Texas native with a passion for helping women and girls achieve everything they were created to be. For more than 20 years, she has worked with national and government agencies to develop and implement multifaceted programs to meet the societal and cultural needs of women and underserved communities. In addition to her role as Deputy Director for the Balm in Gilead, Ms. Price serves as the director for the National Brain Health Center for African Americans. Our third panelist is Mr. Josue Guinart Carreño. He is Director of Global Neuropsychiatry at Biogen. During his 6 years at Biogen, he has worked across various therapeutic areas, including spinal muscular atrophy, neuromuscular disorders, and multiple sclerosis. Prior to his tenure at Biogen, he was a brand lead across several product lines at Procter & Gamble for 10 years. For our audience, throughout this briefing, please feel free to enter your questions into the Q&A box. the Q&A box, not the chat box. We will answer as many of your questions as possible during the Q&A session that follows completion of the opening remarks from all panelists. So our first presenter will be Dr. Berra. Dr. Berra, you have the floor.
Thank you so much. I want to first thank Gretchen and the National Minority Quality Forum for the opportunity to be part of this panel. What I did when I did receive this invitation about a month ago, the first thing I did was to learn more about the mission of the National Minority Quality Forum. And as I read through all the work that this forum has done since its inception, the collaboration, the board, the innovative people that are consultants, it fell in exactly with where my career has been the last 10 years. Healthcare policy and bringing all these various stakeholders together has been what's really driven me in bringing innovation, better access, and health equity with regard to mental health. I've been practicing for about 35 years as a psychiatrist here in California. And the stigma and challenges as a deliverer of mental health care have never been greater. For us to be able to move the bar of outcomes in a positive direction for every citizen in this country will really take all of us, everyone that's on this webinar and all of our connections to move things forward. And I'm optimistic. I do think that things are moving forward. So, again, I'm very happy to now have developed a relationship with the National Minority Quality Forum. As Gretchen mentioned, I've worked with Alliance for Patient Access for the last 2 years. They just developed a mental health working group. Their mission is to decrease any barriers between a provider of healthcare and the person who receives that. And especially in mental health, there's so many barriers that have existed that we're trying to really minimize when we want to provide optimal mental health care. I'm also a cheerleader of these ideas of what our webinar is intended to share today. I think it's time, very much like what John F. Kennedy said in the 1960s, we have to have moonshot thinking. We can't just continue the status quo. We have to think outside the box, as grand and big as possible. I hope by the end of this decade, we are going to look back at 2020 and saying, wow, look where we've come with regard to mental health, access, technology, equity, that every citizen has a right to appropriate, proper, and complete mental health care. I also think healthcare policy with regard to mental health is pretty straightforward. Whenever we identify a problem, let's say it's access or a certain community not having abilities for that new treatment, if we identify a solution, and especially as we're talking to legislators and other decision makers, all of us in this forum today are pretty skilled at talking to decision makers. I found that there's 2 items that really resonate, that you can capture their ear, that you've got an idea and a possible solution, and the possibility that there could be economic savings if that is implemented. And if you have some data showing that, you often do have a receptive ear where that idea may move forward. Now, thinking beyond just the United States, many of you are, probably have some relationships with like the World Health Organization. If you looked at their 2020 report, every year or every decade, they have a national report of what their agenda is. And for the decade of 2020 to 2030, they envision that by 2030, we have a world where mental health is valued, promoted, and protected, where mental health conditions, can be prevented, where everyone can exercise their human rights and access affordable, quality mental health care, where everyone can participate fully in a society free from stigma and discrimination. So it's not just us here in the United States, but this is a worldwide initiative. We recognize that good mental health is the foundation for economic prosperity, social mobility. This really, in my mind, this is a human right that we must help people achieve as best a mental health that they can have, that they can obtain. So those are some thoughts just as a background. So, specifically with regard to health equity here in the United States, we're getting closer to this, but I don't think we quite achieved it, that we have to think of health equity as a priority. And here are some thoughts that are somewhat innovative that I think can really, push us faster in the direction of health equity in mental health here in the United States. Whenever, I'll give one example, but I'll share the concept as a whole. Whenever a new medication comes forward, whenever a new technology comes forward, whenever there's a new, legislative bill coming forward with regard to mental health, I think for us to fast track it toward health equity, and I'll give, I'm a psychiatrist, I work at a university, we do a lot of drug development. I think it's critical as the drug is being developed, often in conjunction with pharmaceutical industry, when the design of that study is taking place, we should ask the question, how will this new medication, this new technology, this bill, if it gets approved, get us closer to health equity? I think we've got to ask the question at the beginning, not further down when that medication is approved, that technology is approved, that bill has been passed. It's got to be asked early. The people developing that technology have to be thinking in that ways at the beginning. And the example I have is something that just was approved 3 weeks ago, and the FDA, and this is about autism, which in certain racial ethnic groups is very hard to access good care. So a company, Linus Biotechnology, just 2 weeks ago was granted an FDA breakthrough device designation for just analyzing one hair strand. You had a high specificity sensitivity that this child may have autism. So I asked one of our child psychiatrists, are you familiar with this? They said, absolutely. Now children at 6 months, 1 year can have access. So I asked, could you look up this study? Who are the people in the trial? They had 280 kids in their trial, and 195 were Caucasian kids, 69 were Asian, only 13 Hispanic, and 9 African American. So if the FDA had asked that question at the beginning, we want you, as you develop this, to think of health equity. So this is a simple example of if that had been asked, I can guarantee you they would have had a different cohort enter. The next question is, how will individuals who have trouble with, accessing care, even achieve, this simple hair strand? So I think that's going to be a critical piece that, this group here, and certainly the National Minority Quality Forum, can really push legislators. That's got to be a question at the very beginning. It's got to be a priority when drug trials are designed, when a new digital technology comes forward. And then just, a few final, words, really as a cheerleader for all of us. This webinar is titled Innovation, Access, and Equity. We all know, probably through our personal experiences, when we see our healthcare provider, that digital technology is going to drive the future of healthcare. So, we must insist that all new technologies that come forward don't further automate a racism and bias. There already is a growing divide as this new technologies come forward, the people that have access and the people that don't. And that certainly was reflected, through the current pandemic that's occurred. So, I feel digital access, to good digital health almost should be a basic right. Like electricity, like heat, access, because that is how people are going to be connected to their healthcare provider. That's how they're going to care for themselves, their families, their community through some source of digital health. So, so all new models must ask that question, how is this system going to address internet access, cellular coverage, person's comfort with digital tools? I like to, again, think outside the box. I think this should be a Medicare beneficiary, that Medicare should in some ways look at low cost or free technology to every citizen in the United States. And, I recently heard from a leading healthcare policy person here in the United States who said, if everybody had a smartphone in the United States, that may be the most important piece for healthcare equity and improving the overall health of our country. So I think we're going in that direction, but we as, critical stakeholders, can really be the driving force.
Thank you,
So
Dr.
those are
Barrett.
some thoughts. Thanks.
Thank you. I now have 5 to 10 follow-up questions for you, but I'm going to turn to Ms. Price first and love to hear your remarks.
Yes, first of all, yes, definitely so much wonderful information that Dr. Barrett just really kind of kicked us off and I think has us all kind of primed and thinking about and want to, yes, definitely thank you, Gretchen, and your entire team there with the National Minority Quality Forum for, putting this together, your work in general as it relates to equity issues, right? Because I think that's where we should have always been focused on equity. Obviously, I think coming into COVID, out of COVID, definitely there's been more emphasis on that. I still don't know if we fully 100% haven't agreed upon of what equity really is. Like in the context of health, I think it's one thing, but for me, and outside of just the things I do professionally, I am a proud Black woman who lives with bipolar disorder type 1 with psychotic features. I'm also a 3-time suicide survivor. I have a son who we're also navigating our mental health landscape with as well. So, this is a conversation that is so needed and so important. And then definitely when we consider, well, what are our challenges when we think about equity? I think one of those is that we've taken, similar to how we've done with other things, is this siloed approach to equity. So if we want to do health equity, we focus on things that are very health specific. But really, if we're thinking about how to drive this needle and how to change the narrative and how to really have the impact that we need, really start to think about what are the real, ROIs when we think about why we need to invest in equity, it goes well beyond what happens inside our existing healthcare systems and structures, especially, I think, under the umbrella of mental health. And I think when I say that, what I mean is thinking, to Dr. Barrett's point, we have to start asking what are the outcomes, right? So beyond wanting to get individuals connected or access or using certain therapeutics or using new technologies or devices, but really thinking, if we know a barrier to that is going to be poverty and or lack of education, are we building in systems in which will help address and or shore up some of those gaps? Because if we don't, then we can, again, I think I saw the new research and the new opportunities in the autism space, but those are my initial questions. How much is this going to cost? Who was in the study? I kind of assumed it was not going to be a diverse mix, just based on history. But those are the questions that, again, we should be asking ahead of time, because now we are building, again, I think in a more equitable fashion. If we think about in the mental health context, we know in recent months that we've had multiple instances where specifically individuals of color who are suffering from serious mental illness, as Gretchen kind of highlighted, who are not getting the care that they needed, not being connected to the services, not having the supports that they need, that are then either subjected to our criminal justice system, which has its own issues when it is looking at equity. And then we're also looking, unfortunately, at a society where the understanding around serious mental illness is just not where it needs to be. And we are putting those who are living with serious mental illness, like myself, in harm's way if we are in the midst of a crisis and not knowing who to call, not feeling safe if we call this person, that the outcome will result in us getting care and services. And I think all of that is something that is an inequitable part of our existing infrastructures when we think about care, and definitely when we think about mental health services. And I think it will require more innovation, more outside the box thinking, like Dr. Barra said. We know that the digital divide has only gotten worse, even with so much shifting to digital spaces because of COVID. We still know that broadband does not exist, period, in many pockets across this country. We know that when it does exist, same thing, those families and houses and communities who need it don't have quality broadband. That's not only impacting your ability to access healthcare services and utilize healthcare services that have, moved into these digital spaces, but it also limits our ability in terms on an economic side. We know that upwards of 92% of jobs today require at least one digital skill that a lot of our communities don't have. We also have data that supports that if we can give these communities one digital skill, we can significantly raise the hourly rate that they make. So now we're talking about economic changes that we can see in these communities by, again, tackling that one issue, but we're then being able to, I think, have greater impact and address multi factors that are really, I think, driving some of the issues and challenges we see. And I think our mental health infrastructures are in that same situation where we really got to think about some more multi-layered, multi-sectoral types of approaches to addressing the challenges that we have.
Thank you. Thank you, Ms. Price. Mr. Guinard Carreño.
Thank you, Gretchen. And I'm just wanted to say I'm honored to be part of this panel today and happy to be joined by everyone on the call. So as Gretchen mentioned, I work at Biogen, working as part of the neuropsychiatry team. And for those that are not familiar with Biogen, Biogen's a leading global biotechnology company, and we've pioneered breakthrough innovations across multiple disease areas such as multiple sclerosis, spinal muscular atrophy, and Alzheimer's disease. And one of the things that is in common with all these diseases is that there's been incredible unmet need in all of these. They're very challenging diseases to address. And I think that's why we're also very interested in mental health, because there's a huge unmet need that I think the other panelists have started to talk about. And even when we just think about, depression, the impact that depression can have on someone's, day-to-day functions is enormous. So, there's incredible unmet need, and this unmet need is recognized at the societal level. Going back to the Surgeon General's first ever report on mental health in the year 2000, when we started talking about mental health and different communities and what kind of impact it could have and what treatments are appropriate. And when we think about it, that's not that long ago. That's just a little over 20 years ago. So, mental health, I think, is still evolving in the way that we're talking about it. And as Dr. Barra mentioned earlier, it's only getting, in some areas, it's only getting worse, right? I think even in 2023, the most recent warnings from the Surgeon General was around the impact of social media on adolescents and the impact that could have, and the impact on loneliness on society, on mental health. So I think society as a whole is more and more attuned to mental health as an issue. And when we think about just depression on its own, around 30% of Americans are going to receive a diagnosis of depression in their lifetime. That's 1 out of every 3 people on this webinar, 1 out of every 3 people that you meet. That's an astounding number. So the chances that, that all of us either have been affected by depression or know someone who's been affected by depression or another mental health illness is quite high. And this has only been increasing over the last 10 years. So, we kind of see this need and we recognize this need, and there's an interest in doing something about it. And there are many vulnerable populations within this broader community that also has tremendous unmet needs that have to be addressed. Think about moms, right? So about 1 out of every 8 mothers with a live birth will experience symptoms of postpartum depression. That's around 500,000 people annually. That's huge. And the reason I call this a vulnerable population is because postpartum depression doesn't just affect the mother, but it affects the child and the family. So a huge unmet need there. When we think about severe mental illness, around 50,000 people in the US take their lives each year. And this is at the most severe end of the spectrum. And these rates have been climbing in the US, even though globally they've been shrinking. And I think that's especially prevalent in younger communities. And lastly, minority or minoritized communities are disproportionately affected by depression. And I think that's why we're all here to kind of address that unmet need and what we can do about it. So, depression affects everyone. And even if you're not the one suffering from depression or a mental health illness, the economic burden, which I think, again, going back to Dr. Barrett's point, what do some policymakers care a lot about? What's the burden, the financial burden on society? Just in 2018, it was estimated that it was around 300 billion just for depression. So, this is enormous if we can all do what we can to solve these issues. And so we believe there's room for innovation here. There's been innovation on the technology front with apps and with the rise of telehealth, especially during this period of the pandemic. There's increased awareness that's more broadly covered. And how can drug innovation catch up? There's been little innovation in the past 20 years. I think things are starting to change in this space. Until we recognize that, in drug development, there's also an opportunity to innovate and bring better therapies to patients. So with that being said, thank you again for the opportunity to be here and looking forward to continue this dialogue. Okay,
thank you. As we enter the Q&A phase of this webinar, I will first say my thanks to the 3 of you for such a thorough and thought-provoking presentations. As a result, therefore, you have answered the first questions I was going to ask you, but I noted that across your 3 presentations, even though you're entering this conversation through a different lens, you all mentioned economic factors in some way, economic access, financial challenges. So I'll start this first question, which I'm actually going to open to all 3 of you. The National Minority Quality Forum's mission is to reduce patient risk and to help assure that the system assigns priority to the reduction of patient risk over the mitigation of financial risk to the system. And now that's not saying that we don't recognize that financial issues affect every aspect, or economic issues affect every aspect of the care continuum, research, delivery, and finance. But given the challenges you've presented, how do you see a way forward in terms of using public policy to eliminate that structural barrier through your particular lens and the environments within which you function, so that we can truly assign priority to patient risk for those with mental health issues, particularly severe mental illness? I'll start with Mr. Guinart Carreño. You're on mute.
My gosh, we just overcame this big hurdle of getting kicked off Zoom, and now I can't take myself off of mute.
That's okay.
All right,
What?
back to basics. Back to basics. Thank you, Gretchen, for the question. And yeah, I think affordability is an issue in access to therapy. And in a recent survey, around 40% of patients called out affordability as one of the reasons for not using mental health services. So I think it is an issue to address. And I think what we're trying to solve for is, how do patients get access to the right therapy for them, the right therapy that's going to address their unique issues according to their providers, and in a way that kind of addresses the whether it's depression or another mental health illness urgently, because we know that the longer that these illnesses last, the greater the impact on that patient and society. And this is, I think, just one of the factors, when we think about some of these barriers. I think stigma is another big barrier. Access to providers and the lack of providers, specifically in mental health, especially in rural communities, I think is another big issue. But I think ensuring that patients have access to that optimal treatment, I think, is critical.
I've got a muting issue. Dr. Barra.
Yeah, that's a great question, and you're absolutely right. All of us did share sort of like economic prosperity and social mobility. There's an economic bit. I think that our answers will not just be from the public sector, from our legislators, but there'll be a public-private partnership that will lead to better access, support of innovation. I do believe that we are seeing a narrative change in the private sector, and more value of good mental health for their workforce. I've heard from many business leaders throughout the United States that they want their employees to have access to mental health. Part of that, many of them, I'm sure, are doing it, for more profitability, but they're valuing if mental health is well at the workspace, and we have the ability to support that, it'll extend to when they go home, to their families, their communities, and so forth. And one thing, Josu, that you just said, the World Economic Forum, which is where all the leaders of the whole world meet in Switzerland. Their theme this past January was the state of the world's well-being, and that's going to lead to continued economic prosperity. So the fact that here are the most powerful economic people in the world, believing well-being is the driving force. So I think as ideas come forward from groups like our group today and the people working with the private sector and continuing to support them in well-being mental health initiatives will be important. They may be looking at it for profitability for their product or their business, which they're maybe, but I think that expands toward just a good work, a working force. So, those were some thoughts that come to mind. Working with the private sector in this initiative, not just leaving it to Capitol Hill or state government or all of these great support groups. Let's bring in the private sector.
That's an interesting frame for that. The Ms. Price, same question.
Yes. So I definitely agree that the solutions, when we think about this, will have to be, again, multi-sectoral. It will have to be both public, it'll have to be private. It will also have to be community, right? And I think it should be community-led with public and private stakeholders, all at the table, I think all with skin in the game, so to speak. And even if we do think about both local, state, and even some of our federal policies, that if we're looking, okay, well, how do we shore up some of these economic challenges? There's just been continued and decades long debates around what is an affordable wage for people to make and earn, right? So can we start to get clear and actually start to pass legislation that is not branded as something that is socialist versus no, this is something that is economically sustainable, and that is also economically beneficial to our communities and to these communities who for decades have been living below the federal poverty line, right? That is going to continue to put those and keep those communities at a deficit, period. Across, especially across, health, because the cost of healthcare continues to rise, but the wages aren't in line with the rising of the cost of just living, nor the wages that individuals are earning. So I think that is a space that legislation could play a big role in us being able to shore up some of that gap. I think if we think about legislation that, we saw where we, I think because of COVID and the infrastructure funding that was within that, there were one-time benefits that a lot of, minoritized communities were able to access, and you could offset childcare costs by that, but we didn't continue those, right? So it's always, we kind of do just one-offs of things. And I think to Dr. Baer's point, like, we've got to do better about of illustrating why this is important. I think of illustrating that there is an economic advantage, I think, for all parties involved when we can say for the next 5 years, for the next 10 years, let's shift funding. Because even looking at budgets, right? We're still continuing to put billions of federal dollars into some research funding, which we still need research, but do we still need research at a $3 billion level if that means that we now have reduced funding when it comes to direct service programs, when we've reduced funding that supports advocacy work, when we've reduced funding to help offset healthcare costs, right? So I think it's some balancing too in terms of our budgets at local, state, and federal levels, and where we are investing those dollars, and is that equitable so that we can then have equitable outcomes. And so I'd love to see, I think policy can help along those fronts. And then I think also policies that get to addressing where we are in some of the workforce components as well. So how do we, because perhaps that's a way, again, to address some of the economic challenges by being able to create programs, especially in this mental health space, that maybe only require a 2-year degree versus a 4-year degree. Can we create programs similar to some of our community healthcare worker models that we've seen that can be replicated in mental health spaces, but then can we have policy back it up to where those services that may be performed by lay and or community educated individuals, can we have it to where there's reimbursement from CMS or reimbursement from our private insurers for those services, because the gap is just too wide in terms of what our workforce looks like from a diversity standpoint. And then also of saying to meet the need is so high. If it's taking 4 years to get just a undergraduate degree, but then to actually become a full-fledged counselor or therapist or psychologist, there's many more years. Think of how many people, as Dr. Carrillo just said, that we've lost to suicide in that span of time. How many individuals who have been misdiagnosed, how many more minority communities have been labeled with schizophrenia when that may not even be the accurate diagnosis, while we're waiting for individuals to get through school. So I think that could also be a space where we could both tackle some of the workforce issues, that then if we're kind of plucking from these minoritized communities to put them in 2-year programs or develop some type of community health educator model that then can allow for reimbursement. So now health systems and clinics and federally qualified health centers can now pay these individuals a living wage coming straight from these communities to then come and serve and maybe become placeholders while we can get people to the psychiatrists and get people to the therapists who are waitlisted right now. So those were my, I think, just initial thoughts on some of the economic challenges and perhaps how policy can help, change some of that.
Okay, thank you. And we've sort of moving into the final phase of this Q&A, and if you don't mind, I'm going to trigger your link this last question also to giving you an opportunity, you three, an opportunity to make a final statement. And it's going to be a compound, complex question, so bear with me. Mr. Guinart Carreño made the statement that 30% of Americans, it's estimated, I assume, are experience depression. And I'm assuming it, I don't know if in your statement that depression falls within the category of serious mental illness or the different levels of depression. 30% is a lot of people, okay? I'm going to assume, therefore, Ms. Price, that includes people who are in the middle class, as well as those who are below the poverty level. Dr. Berra brought the issue, introduced the issue of technology, digital technology into the care paradigm. So my question for the three of you is, given that I think there's consensus here and probably in separate conversations as we go about our daily business, that we've got a mental health crisis in this country that has become visible. I'm going to assume that it was always there. Now, the pandemic triggered visibility for all population cohorts, but what we're looking at is a seriously understudied and undervalued aspect of healthcare. And a concern I have is that because of the way we tend to describe inequities in this country, we tend to default to the affected populations as those who have financial challenges, educational challenges, other socioeconomic challenges. I'm going to say, from my personal experience as well as Ms. Price's, I'm going to say that's not true. So I guess a third part of this is that, or my question is, do we have the data? Because the case that Dr. Berra made was that when you're talking to folks on the Hill, whatever Hill you approach, whether it's in Washington or in a state, it's very, you can make a compelling clinical case for your issue. But what you said was, we also have to give them the, make the case that there's the potential for economic savings. I submit to you that we need to make a solid case for the economic savings, because that's where they're making their decision. But we also need to link broadening the market, broadening access through the policy lens, through the clinical lens, to that more beneficial economic model, rather than somehow looking for ways to minimize access. If Dr. Puckett were here, he would say ration access to mental health services in a way that assigns priorities to those rationed populations by keeping them out of the system rather than bringing them in. I don't know if that's a question or not, or just a statement, but I'm going to ask Dr. Berra to respond to whatever aspect of that first, then Mr. Guinart Carreño, and then Ms. Price. And you've got 8 minutes to do that across the three of you. I can't hear you. You're on mute. There you go.
No, Gretchen, yeah, you really summarize a lot of different parts in what you just conveyed. One thing that I heard early in your summary, you're absolutely right. Even communities that traditionally we've maybe considered don't have the same health equity. I wouldn't want to, compartmentalize and saying access to improved mental health, decreasing stigma, providing resources can still not be achievable. We can still be very creative in ideas to help communities that have had difficulties, challenges in receiving care, receiving, maybe as Pamela mentioned, workforce issues. We have the capability today to help those communities with what, current tools we have. But I do think, as I said earlier, we have to bring that concept to the forefront at every discussion of mental health. Whenever we're talking in schools about, example that came to mind, screening all kids K through 12, that can be done in every community, through the United States. It's not being done. It's being done in, maybe certain pockets of school districts that put some maybe resources or assign somebody there. That should be, across the country, all children should be screened. I mean, that's something that we don't have to put more resources in. But for some reason, some communities are left out in some of these discussions. College campuses, we should provide, faster training, quicker, maybe licensure and support for people to work in maybe underserved areas. We will never have enough mental health providers in the United States for that 30%, access to psychiatric nurse practitioners, psychiatrists, social workers. We have to support our front line, that's including teachers, college professors, the primary care workforce, physician assistants, provide them more training in identifying, evaluating, and treating, because that's really where mental health care is taking place, certainly for a condition like depression. And I think that's where we can then maybe tie in the economic piece, the disability and missed days at work, students dropping out of school. When you look at all that, depression is a big piece of why that happens. So those are some things that came to mind. We have right now the resources to do little tweaks in our approach to mental health, and I think we should take full advantage of that. It's not necessarily new legislation or more monies for a program. We can just readjust our focus, and I think we'll have tremendous impact on mental health, certainly in communities that have had some challenges in accessing that.
We have 2 minutes left. I'm going to split it between Mr. Guinart-Carreño and Ms. Price. And
Yes.
before you start answering, I'm going to ask Ashley to put her email address into the chat box so that all who are with us can forward any additional questions to us or any clarifications, requesting any clarifications. Mr. Guinart-Carreño, that's
Sounds
45
good.
seconds to you.
Ooh, all right. So I will build off of something Dr. Barrett said around kind of like the economic impact of at the individual level, at the family level. So if you have depression and your daily function is affected, let's say you lose your job, let's say there's potential that you can't help your family as you normally would and need to pay for additional services. There's huge economic impact at the personal level. And I think whatever we can do to address that issue, that depression as fast as possible, whether it's through therapy or access to therapy or just getting that patient diagnosed quickly, I think is critical. So I think, I guess my parting thought, inspired from what you said, Gretchen, when Dr. Bear remarked, is like the urgency of treatment, I think is critical to this space. And as you mentioned, not all the barriers are financial. Some of the barriers are very much cultural, for example, stigma-based. I think there's been some data showing that Hispanic and Black patients are less likely to seek treatment. So things like screening, I think broad screening, I think can help address some of those issues too. And continuing to have conversations like this to continue to destigmatize mental health. So I think all of that is critical.
Thank you. Ms. Price, I think 30 seconds to you.
Got you. So I definitely will condense because I definitely just want to ditto of what Dr. Bear and Dr. Carreño just said. Both of you mentioned screening, and I think that's important, but we've got to reimagine where the screening is occurring, because it can't just happen inside our current health infrastructure, because that's not where these minoritized communities are coming to. So that's one. I think the cultural piece that you just mentioned up is extremely significant, both from a community level where there's stigma, but also from the provider in our healthcare system. We've got to also shift and shore up their cultural proficiency to be able to adequately care for individuals from these minoritized communities who are living with and or potentially suffering from serious mental illness. So that would be two. And then three, I think, again, mental health is a cut through across every facet of our being, to be quite specific. So if we can't work, can't hold employment, we can't engage from policy perspective, we can't engage in our communities if the mental health, and I think, yes, that should be our foundation, that should be the common thread, and that also cuts across those socioeconomic factors, to Gretchen's point, that I think we get stuck on. But when we think about mental health, it is impacting across the board, irrespective of educational backgrounds and or your socioeconomic backgrounds. So I think mental health is a great place to start to address some of the challenges that we're having.
Thank you. And our thanks to our audience for joining us and bearing with us during our technical difficulties. I will say the National Alliance for Brain Health and Awareness is going to continue to look at our options for creating structured programming around the issues that have surfaced during this webinar. Goodbye, and everyone have a good afternoon.